I'm delighted today to introduce my good friend, Dr. Caio Nery. He's an associate professor at the Federal University of São Paulo, Brazil, and he's a foot and ankle surgeon at the Albert Einstein Jewish Hospital in São Paulo, Brazil. He's past president of both a Latin American and a Brazilian Foot and Ankle Society, which have names that I cannot pronounce. And of all the lecturers who we asked for a brief bio, he gave us the very briefest. He's far more accomplished than he'll admit to. I have seen him lecture before. He's a wonderful teacher, and I'm looking forward to this lecture.
Oh, all right. So, hello everyone. It's a pleasure for me to be here today. And I would like to, let me see if it's work. I would like to thank very much Dr. Hilary Humans for her friendship and for the opportunity to talk to you about the lesser toes plantar plate tears from the surgeon point of view. I was telling her that it's not easy to talk to radiologists about surgery, but I'll try to do my best and try to make some interesting point to you. This are my disclosures, and somebody can find something related to the subject of this presentation, because I'm a speaker and consultant for Arthroscopy. Okay. In the last decades, the crossover toes deformity and the lesser MTP joint instability called the attention of the foot and ankle surgeons, driven especially by the poor results obtained with the conventional treatment protocols. After Dr. Michael Coughlin's description of the crossover toe deformity in 1987, interest in this condition grew exponentially. The first mention in the literature to the overlapping toes is due to Henry de Vries in his first book, Surgery of the Foot, published in 1959. De Vries suggested some years before that the second MTP joint was the most frequently dislocated joint of the human body. Since then, several authors were interested in the lesser toe deformities. During the 50s and 60s, the surgical procedures were directed to the toes, especially the soft tissue contractures, bone deformities, and stiffness. The main objective of the treatment at that moment was to create room to achieve a deformity correction. In the 70s, attention turned to the MTP joints and to the role of the muscle imbalance in the genesis of the deformities. Surgical treatment was based on the soft tissue contractures and tendon transfers. In the middle 90s, the plantar plate anatomy studies were deepened until 1998, when Ford and colleagues suggested for the first time in the literature the plantar plate direct repair as an option to the treatment of the crossover toe. Among several anatomical structures involved in the MTP joint stabilization, the plantar plate plays a very important role. Plantar plate is a firm and flexible fiber cartilaginous structure with a strong distal insertion to the proximal phalanx and a soft proximal insertion to the neck of the metatarsal. Two strong bands of the plantar fascia penetrate the plantar plate by its proximal edge. Lateral and medial intermetatarsal ligaments and accessory collateral ligaments provide more stability to the plantar plate. I would like to stress some anatomical details with you. From the medial and lateral metatarsal tubercles to the proximal phalanx plantar prominences run the proper collateral ligaments. These ligaments have little or no insertion onto the plantar plate, but they are very important to the joint stability. The accessory collateral ligaments originate from the same metatarsal tubercles and inserts directly onto the medial and lateral borders of the plantar plate. From both sides, the plantar plate receives connection from the deep transverse intermetatarsal ligaments and on the underside serves as a ceiling and anchor for the fibrous flexor tendon tunnel. The plantar interosseous muscles runs medially just adjacent to the plantar plate, while the dorsal interosseous muscles runs laterally. The lumbrical muscle runs plantar and medially to the plantar plate, just beneath the deep transverse intermetatarsal ligament. Both medial and lateral neurovascular bundles run deeply under the plantar plate. In this anatomical preparation by Poggiolano, the joint capsule was opened to show the metatarsal head and the proximal phalanx of the second toe. The extensor hood and the extensor tendons were removed. After the metatarsal head resection, we can clearly see the plantar plate at the bottom of the joint acting as a comfortable and stable cradle for the metatarsal head. With the light traction on the toe, we can see almost the entire plantar plate and its rectangular shape. The plantar plate, detached from the distal insertion, appears as a strong structure, 2 to 3 millimeters thick at this point. Just below the plantar plate, we can see the flexor digitalis longus and brevis tendons. The plantar plate has 3 layers, as we can see here. The superficial layer is made of a smooth fibrocartilaginous tissue. The intermediate layer is composed of longitudinal-oriented fibers that come from plantar fascia, and the deep layer is composed by transverse-oriented fibers resulting from the merging of the plantar intermetatarsal ligaments. The major composition of the MTP plantar plate contains type 1 and type 2 collagen fibers woven together to create a dense fibrous network that acts as a cushion to support compressive and shearing forces transferred to the forefoot during weight bearing. Chronic hyperextension forces applied to the MTP joints can lead the plantar plate and capsular attachments to become attenuated and insufficient, causing loss of the joint stability. The clinical picture starts with the onset of acute pain under the metatarsal head, usually the second after a party or some high heel extravaganza. Typically, pain is concentrated in the distal lateral border of the metatarsal head around the point marked with an X in this picture. What can cause some difficulty to differentiate from the second intermetatarsal space neuroma. Soon, acute inflammatory signals appear and a typical arthritis can be found. At the very beginning, only light widening of the interdigital space can be noticed. With time, the toes widening progresses till the affected toes lose contact with the ground, and angular and rotational toe deformities appear. The most common combination is the elevation with varus and supination, followed by the elevation with valgus and pronation, and elevation with varus alone. The MTP drawer test, conceived by Thompson and Hamilton, is the most specific and reliable clinical test to diagnose and graduate the MTP joint instability. With the Hamilton-Thompson MTP drawer test, we can classify the joint instability from a grade 0 stable joint to a completely dislocated and irreducible grade 4 joint. The Boucher and Hoyt paper pull-out test is important to evaluate the digital purchase before and after the plantar plate repair. With the patient standing, a strip of paper is placed beneath the affected toe, and the patient is asked to plantar flex the digit. If the patient is able to prevent the paper strip to being pulled out from beneath the digit, this is considered as normal test. When the patient is able to resist in some way, but not so efficiently so that the paper can be removed, the result is considered reduced. And when the power exerted to the paper strip is so weak so that it can be easily removed, the test is considered definitely abnormal. Based on clinical signals such as the alignment of the lancet toes, presence and location of pain, and the MTP drawer test, we proposed a clinical staging system that proved to be a valuable tool in the management of the plantar plate lesions. In 2014, we reviewed data of 100 MTP joints of 68 patients complaining of pain and instability of these joints. 2/3 of the patients were females, and the second and third dose were the most frequently affected. Evaluating the importance and significance of each clinical findings in the MTP joint instability, we noticed that some of them appear in almost all patients. Just like the MTP drawer test, pain under the metatarsal head, toe elevation, and the progressive loosening of the toe purchase. The axial toe deviation, widening of the interdigital space, loosening of the ground touch, and the crossover toe deformity appears in 70 to 90% of the patients. While the clinical signals appears in less expressive frequencies, but the more important finding in our research is that those clinical findings that appears in blue box in this slide are statistically related with the plantar plate lesions and can help us with the clinical differentiation and anatomic typing of the grading of the lesions. The clinical diagnosis can be complemented by imaging, of course. The splaying of the second and third toes and the protrusion of the second metatarsal head in standing plane radiographs has been correlated with plantar plate tears. Humans and colleagues established a strong correlation between 4.5 millimeters of metatarsal head protrusion and the onset of the plantar plate lesions. In a recent paper comparing the second metatarsal protrusion measures in plane radiographs and MRI images, we identify the association with the metatarsal protrusion and the plantar plate tears. The overland cutoff value for the second metatarsal was found to be 5.5 millimeters in the plane radiographs. The MRI is the most powerful tool to identify, typify, and measure plantar plate lesions. A T2 high signal zone at the distal insertion of the plantar plate in the sagittal view is one of the most important MRI findings of a transverse plantar plate tear. The same hypersignal can be seen in a coronal plane, indicating a secondary longitudinal lesion. Combining the MRI images in different planes and knowledge of the anatomical grading system of plantar plate tears is capital to expand the diagnostic accuracy. One step ahead of the imaging study in the plantar plate tears and MTP joint instability constitute the search for predictive parameters. The number one MRI predictive finding of plantar plate lesion is the pericapsular soft tissue thickening with 95% of accuracy and specificity. Using plantar surgical findings as the gold standard for the diagnosis in plantar plate lesions, we confirm that the pericapsular fibrosis is highly sensitive, specific, and accurate for the diagnosis of plantar plate tears. The plantar plate proximal phalanx distance is also a very good parameter in this matter, and we determined 2.8 millimeters as the cutoff value for the plantar plate tears diagnosis. The supination of the central metatarsal also correlates with the MTP joint instability, with 24 degrees indicating a possible correlation and 36 degrees or more indicating a strong correlation. Another new MRI signals that strong suggests the plantar plate lesion is the enthesitis at the plantar plate phalangeal insertion that could be suspected when there is a reactive bone marrow edema at the base of the proximal phalanx and productive changes at the insertion site. From the very beginning of our study of plantar plate lesions, we use the MTP joint arthroscopy as a diagnostic tool. Let me introduce you to the most common arthroscopic aspect of the lesser MTP joint. In the upper part of the image, we can see the inferior border of the proximal articular surface of the proximal phalanx. In the lower part of the image, we can see the round aspect of the metatarsal head. The central structure, ivory colored, is the normal plantar plate. In the center of the image, there is a synovial recess, a normal finding formed between the two bundles of the plantar plate. Data collected with these arthroscopy from our patients allows us to develop an anatomic grading system. According to it, grade 0 represents the plantar plate attenuation or discoloration. Grade 1 represents a partial transverse distal tear adjacent to the medial or lateral insertion of the plantar plate into the proximal phalanx. Grade 2 refers to a complete transverse distal tear of the plantar plate. Grade 3 refers to a combination of transverse and longitudinal extensive tears that can assume the 7 or the T shapes. The grade 4 represents an extensive tear with a buttonhole that leads the dislocation of the metatarsophalangeal joint. This anatomic grading system directly correlates with the clinical grading system presented before. With this information in hand, we proposed a treatment algorithm to face the different grades of the plantar plate injuries. We have already tested this treatment algorithm in the last 10 years and published our results. The rationale used in the base of, as the base of our treatment algorithm includes the ability to correct the metatarsal parabola, the possibility to unload the metatarsal head, and to create enough room to assess the plantar plate in order to reinsert it and repair it, restoring the metatarsophalangeal joint stability by using, if possible, the original local tissues. We have to pay attention to the big picture and treat the whole package. That means we have to include the proximal and distal interphalangeal joints in our surgical plans. These three first goals can be achieved through the most popular metatarsal osteotomy ever, created by the Dr. Lois Scott Wales Sr. and known as the Weil osteotomy. The Weil procedure is an oblique distal metatarsal osteotomy used to reduce the protrusion of the metatarsal head by pushing it proximally. Sometimes it is necessary to remove a slice of bone to elevate the metatarsal head in order to reduce the pressure underneath. The combination of shortening and elevation of the metatarsal head is a very powerful tool to treat the metatarsalgia that often comes with subtle deformities. It's important to stress some details of the Weil's osteotomy in order to avoid post-operative complications. The ideal plane for the Weil's osteotomy cut is parallel to the ground, but this is almost impossible to achieve. For anatomic and technical reasons, the smallest angle possible to perform a Weil's osteotomy was found to be 10 degrees relative to the ground. With this undulation, the metatarsal head will be depressed while being proximally shifted in a proportion of 3 millimeters of depression for each 5 millimeters of shortening. This may explain the residual plantar forefoot pain as well as the transverse metatarsalgia after an unsuccessful Weil's osteotomy. The most common cause of intrinsic muscle weakness is the excessive shortening and depression of the metatarsal head. Shortening causes laxity of the flexor musculature, and depression determines a plantar translation of the rotation axis of the joint. The interosseous muscles, which originally act as flexors of the metatarsophalangeal joint, are transformed into extensors by moving to a point above the new rotation axis of that joint. This condition produces the floating toe deformity, and dorsiflexion contractures are frequently seen. The Weil osteotomy is a very important step in our protocol for the plantar plate repair. For this reason, some technical tips must be followed to achieve the desired results. The entry point of the osteotomy must be positioned 1 or 2 millimeters distal to the dorsal edge of the metatarsal head cartilage. The angulation of the osteotomy must be as close as possible to the ground plane, and the proximal dislocation of the metatarsal head must not exceed 3 millimeters. We collected data from 203 patients with 292 metatarsophalangeal joints operated according to our protocol, with a minimum follow-up of 2 years. We are quite satisfied with the quality of the results of patients with grade 0 and 1 lesions treated arthroscopically through radiofrequency tissue shrinkage combined with a wire osteotomy in the main treatment option. With the heating of the collagen fibers through the application of a sequence of 2-second shots of radiofrequency, we change its tertiary structure, which determines the progressive tensioning of the tissue with no detrimental effects. 99 joints were treated this way, 34% of the total, and the average AOFAS 4-foot score, which was 59 points in the preoperative period, rose to 90 points out of 100 after treatment, remaining high even in patients treated for the longest time. A comparable result was obtained in 169 grade 2 and 3 MTP joints, 58% of our sample, treated through the arthroscopic or open direct repair of the plantar plate. The AOFAS 4-foot score rose from 54 points preoperatively to 87 points after the treatment. The easiest and elegant way to pass the sutures on the plantar plate is with the mini scorpion or the pigtail micro suture lasso developed by Dr. Coughlin for Arthrex. In a matter of 10 seconds, the sutures were completed in a safe and a solid manner. They are then passed through bone holes at the base of the proximal phalanx. In the sequence, 1 or 2 quick screws are used to fix the wire osteotomy at the desired position. Once the osteotomy fixation was done, the structures must be tightened with a toe and 20 degrees of plantar flexion to permit the better tensioning of the plantar plate. Testing the stability of the joint from side to side will give us directions about the amount of tension and which structures to reeve in order to achieve the ideal joint balance and positioning. The worst results were observed in the grade 4 lesions in which there was no more viable tissue for repair. Until very recently, we only had the transfer of the flexor longus tendon to the extensor hood, the Parrish technique, for the treatment of these patients. In this particular group of 24 patients, 8% of the total, the AOFAS 4-foot score rose from 37 to 76 points, with a significant number of dissatisfied patients. In an attempt to improve the results of grade 4 patients, a technique of reconstruct the plantar plate with a fiber tape has recently emerged. A bone tunnel is made at the base of the proximal phalanx with a single dorsal entrance and 2 plantar exits. A number 2 fiber tape is passed through this tunnel as shown here. Another bone tunnel is made at the distal metatarsal diaphysis, taking care not to jeopardy the screw used to fix while osteotomy. With the help of a suture passer, both ends of the fiber tape are driven through this bone tunnel. At the left-hand side picture, we can see the correct position of the fiber tape at the bottom of the joint. A 3 mm biotenodesis screw is used to fix the fiber tape at the phalangeal bone hole. A gentle move reduces the MTP joint while the fiber tape is pulled proximally, reconstructing and stabilizing the plantar plate. When the appropriate tension is obtained, a second 3 mm biotenodesis screw is introduced at the proximal bone hole, stabilizing the construct. It's too soon to say something about the long-term results of this technique, but it is still working very nicely so far. Now, I would like to discuss with you a crucial problem. Why are some plantar plate repairs not doing well? we had a 10% complication and unsatisfactory results rate in our series. Most of these patients complain about the elevation and weakness of the operated toe, retracted scar, and the dorsal skin, and the presence of the secondary metatarsalgia. The first line of defense against the toe elevation, weakness, and metatarsalgia should be instituted at the very time of the surgery by avoiding the excessive shortening and depression of the metatarsal head during the whilst distal metatarsal osteotomy, as already discussed. The delicate manipulation of the anatomical structures and a careful hemostasis before closing surgical incisions prevents the formation of adhesions and hypertrophic retracted scar tissue. As important as the surgical technique is the correct immobilization and protection of the operated toe in the following 6 weeks post-operatively. Together with an early rehabilitation program that seeks joint mobility and strength of the flexor muscles, avoiding impact and extension of the MTP joints during the healing process. For obvious reasons, wearing high-heel shoes should be avoided for 6 months. Before finishing, I would like to share with you the essence of the surgeon's view on this treatment of plantar plate injuries. Spare no efforts to diagnose correctly think plantar plate lesion. Strictly follow the recommendations and all steps of the choosing surgical technique. Be careful with the positioning and protection of the operated toes in the post-operative period, paying special attention to taping and with the regular use of the post-operative shoes. Start an early and aggressive rehabilitation program that favors joint flexibility and strength of the flexor muscles. And of course, get a good look. Thank you very much for your attention.
That was wonderful. Thank you. I'm looking to see if anyone has questions. Bearing, maybe you can help me with that.
No, I don't see any questions in the chat box.
So Caio, I constantly hear that postoperative stiffness is the major problem, but in your experience, is this a challenge with the careful technique and rehabilitation protocol you described?
Yes, I think that we learn from our own errors. And I think that we are dealing with very delicate structures in a very small place and very difficult to see under it and everything. And you have to be absolutely delicate to deal with these tissues. And after that, it's very important to reconstruct all of them. If you leave some partial tear of the collateral ligament alone, it's sure that it will be reconstructed with scar tissue. And the scar tissue is kind of hard, is adherent to the vicinity, and of course the toe will be kind of rigid. And if you have some kind of bleeding in the post-operative period at the dorsal aspect of the joint, of course, this will cause some retraction and scar tissue, and the toe will be pushed up. Sorry about that. And I think that it's imperative to move plantarly, very in the very beginning of the rehabilitation program, and to keep the toes in 20 degrees of flexion, kind of stretching the dorsal tissues. And I think that very rarely we have to do some surgical liberation or plasty to free all these tissues, but sometimes we have to do it.
I have a lot of questions in my head, but a couple of them, in rare instances, I find it difficult, even on MRI. I do a lot of 4-foot ultrasound, but even on MRI, it can be difficult to differentiate between a pseudoneuroma, the pericapsular fibrosis associated with plantar plate degeneration and tear, from a true neuroma. And your repair is all intracapsular.
Yeah.
So you don't necessarily explore the web space, right? So what happens? Are you resecting the pseudoneuroma when it's there? I mean, the nerve is going by, right?
Yeah.
And sometimes I can't differentiate. So I end up, reporting a non-specific web space mass, which is usually so large, I can't tell if it's eccentric or centric. How do you deal with those cases?
I think that is a very, very important question. I know that you are concerning about it for a long time now. And I can tell you something. When you are facing a real neuroma, this tissue is not adhered, is not quite adherent to the plantar plate. So you can easily remove the neuroma from the vicinity of the plantar plate. On the other hand, when you are dealing with the pseudoneuroma, it's kind of being a part of the lateral portion or even the medial portion of the plantar plate. There's a step in the technique in which I have to see the free border of the plantar plate and to free the flexor tunnels to create a space for me to put the sutures on it.
All right.
Okay, in this moment, I can see the lateral and the medial portion of the under vision of my plantar plate. And if I see something absolutely adhered to the plantar plate itself, this is a pseudoneuroma. And if I easily put it out, I consider this a very important signal that this was a neuroma. And I can see the interspace through the same incision. So I dissect very, very nicely, and I see that there's something coming with the neurovascular bundle, and I can do the diagnosis. And you know, we have talked about this before. It's very rare for me to find a real neuroma in the second space. So I think that this is a very important information.
And yet the literature says it's the second most common location, and it's not a small percentage. It's something like, close to 40-something%. I think that's a lie.
Yes, it's the most frequent and the second most frequent, but it's rare. It's
right.
Rare. And after we discussed this neuroma that you created, that you define it, I became more confident. Leave it alone, because it is a scar tissue. And if I restore the balance of the joint, I can imagine that it will be kind of a help on the healing process. And after that, it will be remodeled to a very strong tissue. So we don't have to take it off regularly.
I won't hold everyone. I have one more question. We do a lot of ultrasounds, some of us, and we're constantly asked by the referrers to squirt steroids, right? And so I know that I I carefully look at the plantar plate before I agree to squirt steroids in the web space. I'm not sure that everybody is so concerned about this, but is there a problem? Have you ever seen problems with the surgical outcomes? For people who squirt so much steroids, we also spend a lot of time worrying about the repercussions of putting the steroids where we squirt them. Is there a problem if somebody is going to contemplate surgery in that post-intervention period in terms of healing?
Yes, sometimes I think that the steroids are not a good option for treating this pathology. I think that we will put you reduce the pain, we will reduce the complaining, but in somehow we will put a worse scenario for the next time, the next crisis. So sometimes we find some crystals inside the joint or nearby the plantar plate. Very often we see the lesion goes on very rapidly, and I am sure that we are kind of prejudicing our patients, because taking off the pain and taking giving some comfort to do the exercises or impactions over the plantar plate, it will be worse than not doing nothing. So I don't agree with corticosteroids shots, but I do understand that it's very popular.
Do you see any untoward effects from stem cell or PRP injection? I mean, there are all sorts of things that our referrers are treating people with.
I didn't see any evidence of this working for the patient. We really need more studies about that, not level 1 or level 2 studies. But I think that the injection has a participation on jeoparding the results, because we have a volume of something inside, the possibility to infection or something like that. So I didn't like to put anything inside the joint without knowing where I am. Of course, with ultrasound guiding, you can be more specific, but I don't want to put nothing inside the joint or nearby the joint, because it's not worth.
Right.
I'm sorry.
It's okay. That's not a problem for me. Well, I've thoroughly enjoyed this. I've learned a lot. I always love seeing your illustrations. They are incredible for the audience. Dr. Nery is an amazing artist, and he makes his own illustrations, which he shares with me. So.
And we have 2 comments in the chat box.
Okay.
Agreeing with things that were said here. One is, I will stop writing neuromas in the digital space, with a smiley face. And then I agree, I look for plantar plate tears prior to injections into the web space too. So you're not alone.
Thank you.
I think we're in the minority. Thank you so much, Caio. Go enjoy your warm sunshine. I'm very jealous. Thank you so much.
I do appreciate your invitation, and I'm very, very honored to be with you. And I thank you very much for your friendship as always. Thank you.